Hi everyone, I'm Dr. Brian Haas. I'm the National Medical Director at Ascend Hospice and the founder of Hospice Intelligence. Today we're diving into one of the most frequently misunderstood and poorly documented conditions in hospice care. That's COPD. Despite being a leading cause of death globally, COPD documentation continues to be one of the top reasons for Medicare hospice denials. But here's the thing. Most of these patients do qualify. The problem isn't the care. It's how we document it. So let's walk through how to identify, capture, and document COPD decline in a way that meets CMS expectations, supports your clinical judgment, and protects your patient's hospice benefit. COPD is part of the broader pulmonary disease LCD. It's a set of clinical guidelines that Medicare uses to help determine hospice eligibility for patients with end-stage lung conditions. Now, while COPD is specifically named, it is important to understand that it falls under this umbrella of pulmonary conditions, alongside things like pulmonary fibrosis and other chronic respiratory illnesses. What makes this especially tricky is that Medicare doesn't require every single LCD criterion to be met. They give guidance, but not absolutes. That puts hospice teams in a challenging position. How many indicators are enough? What if your patient meets some, but not all? This ambiguity can lead to inconsistent documentation and potential denials. That's why accurate, comparative, and objective documentation is so important, and why tools like Hospice Intelligence help nurses stay on track with what the LCDs are really asking for. Now, let's start with what the Medicare LCD for pulmonary disease actually requires. To certify a patient for hospice based upon COPD, Medicare provides guidance through local coverage determinants, LCDs. These LCDs outline clinical signs and objective criteria that, when present, support terminal diagnosis. But here's the challenge. Medicare doesn't explicitly state that all of these criteria must be met. This ambiguity leaves many clinicians wondering how much is enough or how little is too little, and that gray area can create doubt and inconsistent documentation. So while these LCD items are not absolute checkboxes, they serve as a clinical framework. The more elements you can document, the stronger your case. So let's walk through what those disease-specific and general decline indicators look like. So first, we have disabling dyspnea at rest. Often poor or unresponsive to bronchodilator therapy, resulting in decreased functional capacity, such as a bed-to-chair existence. Fatigue and chronic cough is a key indicator of decline. Now, hypoxemia at rest on room air, as evidenced by a PO2 of less than 55 millimeters of mercury or an O2 saturation less than 88%, determined by either arterial blood gases or an oxygen saturation monitor, qualifies as supportive documentation under that LCD. Now, additionally, hypercapnia, shown by a PCO2 of greater than 50 millimeters of mercury, may indicate further disease severity as well. This data may be obtained from recent hospital records, ideally within the past 3 months. Another very common finding is resting tachycardia, and that's a heart rate above 100 beats per minute. Another one is cor pulmonale, or right-sided heart failure. Progressive decline despite optimal therapy, so meaning that the patient is on extensive bronchodilator therapy but is not able to receive that type of therapy, or they're receiving it but not responding to therapy. Recurrent or intractable infection like pneumonia, sepsis, or pyelonephritis. Intractable cough. Again, intractable cough can be somewhat challenging because these patients often have a cough. Are they taking medicines to help mitigate that cough? If so, and they still have the cough, I would say that's intractable. Now, we need to not forget those general decline criteria as well, because these are what help to identify that the patient is continuing to show decline. Have they had a weight loss of greater than 10% in the past 6 months? Is their albumin less than 2.5%? Is their PPS less than 50%? Have they developed progressive stage 3 or 4 pressure ulcers? Do they have declines in systolic blood pressure to below 90 or progressive postural hypotension? Now, here's the catch. Nurses often observe these indicators without documenting them explicitly. That's what puts us at risk for denials. So let's look at common audit failures. So a nurse might write, the patient remains on 2 liters of oxygen with a poor appetite and shortness of breath continues. Now, at first glance, that seems relatively reasonable, but it tells Medicare nothing really about the terminal decline. Here's another way to say it. Instead, during the last certification period, the patient required 2 liters of O2 continuously. Now they require 2.5 liters continuously to maintain O2 saturations at 88%. Persistent dyspnea at rest. PPS has declined from 50% to 40%. The patient's BMI has dropped from 19.2 to 17.3. Their appetite remains poor with less than 25% intake. During the certification period, the patient experienced 2 exacerbations requiring both steroids and antibiotics. Now, that clearly captures oxygen dependency, functional decline, nutritional loss, and exacerbation history, all of which support the LCD criteria. Now, since implementing hospice intelligence, one of the most commonly underreported findings we've identified is resting tachycardia. This is a frequent and clinically significant sign in patients with severe pulmonary disease. Due to reduced functional lung volume and impaired oxygen exchange, these patients often require a higher resting heart rate to compensate for poor oxygenation. However, because it's such a common finding, it's often overlooked in documentation. This is where hospice intelligence helps clinicians recognize and record this important detail as a supportive indicator of disease severity under the LCD. So now I'd like to show you a screen demo. I want to show you how hospice intelligence helps you catch these details before CMS does. So let's go ahead and share our screen. And we're going to come into Hospice Intelligence and we're going to go ahead and log in with our user and credential information. Now, here you will enter the patient's name. We're going to go ahead and do testing. As you can see, this is my testing frame for Hospice Intelligence. And we're going to go ahead and select our pulmonary disease checklist. And I just happen to have a pre-templated note to help us in this process. And so this note clearly states, for those of you that are listening and not watching this, we have a 70-year-old male with COPD and several comorbidities, including coronary artery disease, diabetes mellitus type 2, hypertension, and atrial fibrillation. Patient is homebound and lives with his wife. He uses 4 liters of oxygen continuously and takes nebulizer treatments twice daily. He reports feeling more fatigued lately and is having increasing difficulty with activity. Shortness of breath occurs with exertion and conversation. He gets winded easily and uses a walker or rolling chair to move around the house. Patient states he has had some weight loss but isn't sure of the exact amount. Appetite is decreased. He used his E-kit once this certification period due to a flare-up of symptoms. Edema is noted in both legs. Patient reports sleeping more and going to bed earlier. Now, at first glance, this is a relatively good pulmonary disease checklist note, certification of terminal illness. We're going to go ahead and evaluate the note and see what criteria the AI is able to identify that we've done. So it's right now telling us, based upon our score, that we're kind of questioning the eligibility of this patient because we only have 5 of the documented LCD criteria present in this one. We have the decreased functional capacity, increased difficulty with activity, shortness of breath occurring with exertion, and using continuous oxygen. Now we have over here disabling dyspnea at rest, poor, unresponsive to bronchodilators. So we can further clarify this because he does have the shortness of breath occurring with exertion and conversation. But we didn't say that it was disabling, and that's a really key factor. So I would assume that this shortness of breath occurs with exertion and conversation. He gets winded easily and uses a walker or a rolling chair to move around the house. That means that he's disabled, right? So we want to put those key words in there. So we can change this here to say, patient is unable to function well in the home environment. Next, we can come down here to the hypoxemia at rest on room air, and we can add in. Next, we can continue to move down, and this is where we find this resting tachycardia. I would assume that based upon the report that I'm reading, that this patient probably has some level of resting tachycardia. So heart rate is frequently above 100 beats per minute when sitting. Now we can continue to go through this and say that his PPS is 40% to clarify that even more, and then we're going to revise the note. This way the AI will go ahead and rewrite our note for us, and we'll be able to use this in the future. So let's go ahead and stop sharing our screen and come back to our rest of our presentation. So based upon these answers, the tool generated a Medicare compliant narrative that you can then paste directly into your EMR. So this is not just time saving, it's audit prevention. Now, what we often consider normal in COPD, tripod positioning, resting tachycardia, 24/7 oxygen use, it isn't just clinical detail, it's documentation gold. CMS doesn't see normal, they see checkboxes, and you have to connect the dots. Dyspnea plus oxygen plus poor intake plus low PPS, that equals your eligibility. The patient's decline is real, and hospice intelligence just makes you capture it the way Medicare wants to see it. If you've ever had a denial and thought, but that patient was clearly dying, you are not alone. It's not about the care you give, it's about how you prove it on paper. Hospice Intelligence is your compliance co-pilot. Use it to flag those missing LCD documents, simplify your complex documentation. Let's protect the benefit and the dignity of every hospice patient. You can, of course, learn more at hospiceintelligence.com, and don't forget to like, subscribe, and share this with a fellow hospice nurse or medical director. Thank you again for coming in and tuning into the Hospice Intelligence Podcast. We appreciate your time and attention. Thank you.